Good evening to everyone. I'm happy for the invite, and I'm very excited to be part of this evening's talk on mental health. One of the things that excites me about this whole talk is the fact that it gives us an opportunity to demystify mental health. A lot of people have various impressions about mental health, but I guess with such opportunities, people get to learn and know the rudiments of it, and therefore find it friendly instead of the wrong impressions they have out there. So just like Albert Riley said, I'm talking on depression, anxiety, and schizophrenia. I'm doing my best to be as simple as possible so that we are able to grab a lot of things by the end of the day. So we start with depression. So I asked the first question, what is depression? As we all know, it is something that is so common in everybody's mouth, and we always hear people, oh, he's depressed. Most of my patients I see up here, the relatives will call you and say, oh, he has some depression. Sometimes it's really, they are talking about something way different, but they perceive it to be depression. So let's see if at the end of the day, we'll be able to know what depression is, how to identify it, and then what to do if we were able to identify it. So it's a very common and highly treatable medical illness. It affects both the physical, mental, and emotional well-being of an individual. It affects basically everyday activities, like even eating and sleeping. It also affects how people think about things and how they feel about themselves. So in contrast to normal emotional experiences of sadness, loss, or passing mood states, like if you lose a relative and you were sad, or if you lost your job and you were sad, or something bad happened to you and you were feeling sad, that is not depression. But then when we talk about clinical depression, we are referring to a persistent state of sadness, a persistent mood change in terms as in you feeling sad about something. When it becomes persistent, then we are probably entering the realms of depression. And it can interfere significantly with an individual's ability to function. It creates that tendency for you to give up. You feel like giving up. You feel as if nothing else is working for you. You feel as if your thoughts are predominantly negative, and you feel like life is not worth it anymore. Again, the persistence of this takes you more into the realm of depression. I mean, we are going to look at the symptoms as we go along. Usually, symptoms of depression may last for months, and especially when it becomes recurrent, it can even go for years, So now, if we say someone has depression, what are some of the things that we are looking for in that particular individual? The feeling of sadness, feeling down, loss of interest in things that you usually would enjoy, what we call anhedonia. Feeling slowed or restless. But feeling slowed is what we call the person the psychomotor retardation, the person being retarded in terms of their thoughts and in terms of their actions. Having trouble sleeping, there could be insomnia, or either they are sleeping too little or they sleep too much. There's loss of energy. They easily feel tired at the least thing they do, and it's mostly all the time. They have an increased or decreased appetite, and therefore increase or decreased weight gain. So some might lose weight because of the decreased appetite. Some might put on weight because of the increased appetite, Having problems concentrating, thinking, remembering, or even making decisions. It becomes a big challenge for people who are depressed. They feel worthless and they feel guilty. They have thoughts of death or suicide and even self-harm. Now, people with, as we go along, we will see, we talk about major depression and all. People with major depression would experience at least 5 of the symptoms that we have mentioned, which happen in most parts of the day, nearly every day for at least 2 weeks. So by the time we are saying someone has depression, the person should be exhibiting these symptoms for most parts of the day and nearly almost every day for at least 2 weeks. So if these symptoms that are running per the definition are not up to 2 weeks, you may not necessarily run to say the person has depression. It might not necessarily be depression. But for it to be depression, if the person is experiencing these symptoms lasting for at least 2 weeks, then we are thinking about possible depression. Now, these symptoms cause clinically significant distress or impairment in their social, occupational, or other important areas of function. So it affects their activities, possibly activities of daily living, things that ordinarily they would do without any stress. Now they are unable to perform them because they have depression. One may then ask, what are the causes of this, if you like, condition we call depression? Now, basically, the causes are unknown, and like almost all mental health conditions. But some theories propound that, or we know that there could be genetic associations. Okay, said that if you had a relative or maybe a first-degree relative who probably has or has suffered depression, then it increases your own chances of possibly also developing or suffering depression. It is not like a straight path to say that once my mother suffered depression, automatically I'll suffer depression. It only increases your risk of having depression. However, depression can also occur in people, like I say again, who have no family history of depression. So once again, you cannot necessarily say that it is only found amongst people who have genetic predisposition or who are genetically predisposed. There are also environmental factors. So if you lost your job, like in our current economic situations where money is very hard to come by, you unfortunately have to lose your job. You look at the responsibilities around you. You are wondering how you'll be able to cope. In that particular case, it may trigger or predispose you to developing depression. Difficult relationships, again, like I mentioned, financial challenges, or any stressful change in your life pattern can trigger a depressive episode. Other causes or other associations could be physical illness. People who have chronic medical conditions, chronic illnesses, terminal illnesses like cancers, they could also, be a trigger or predispose an individual to developing depression. Drugs can also induce depressive symptoms like the beta blockers, the atenolol, that atenolol, propranolol, those ones are beta blockers. They can also trigger or induce depression. Corticosteroids and drugs like that, Also hormonal changes, especially in our sisters, our mothers and wives. Postmenopausal depression as a result of hormonal changes, postpartum depressions also as a result of hormonal changes. So we should be aware of all these things. Personality characteristics. For some people, they generally experience low self-esteem. They are pessimistic about the world. They have low stress tolerance. People with such personalities are more likely to be predisposed or to experience depression. Then there's also the biological component, which usually comes a little more complicated. But I guess what we have discussed earlier, it's a bit simpler to be able to comprehend, understand, Apart from that, so like current thinking explores problems in the brain functioning in the following areas, like in the limbic system, the neurotransmitters, neurons, and endocrine system, But again, like I mentioned, let's not forget personality changes, hormonal changes, drug-induced causes, physical illnesses, genetic and environmental causes, Now, always let us remember that you cannot pinpoint just one particular event and say this is the one what caused depression. A lot of the times it's a combination of either genetic factors, the psychological and environmental and even biological factors that will trigger the onset of a depressive episode or depressive disorder. And so it is not that the fact that someone lost a relative does not necessarily mean the person will become depressed, but several other factors could contribute to this depression. So if someone had a genetic predisposition and then the person lost a relative in such a harsh way that the person is struggling to handle, the person's resilience level is probably very low, that person has a higher tendency to develop depression. compared to another person, probably with genetic predisposition, but is more resilient and is able to accept change easily. That person might have a lower chance of developing depression. Now, in terms of depression, in terms of its severity, we could have major depression and then maybe mild to moderate depression, you know. So for the symptoms we mentioned earlier, for people who experience or who are diagnosed of major depression, they at least have 5 to 9 symptoms of the depressive symptoms that we mentioned earlier, including loss of interest or pleasure in activities that previously brought them pleasure, depressed mood, and then also these symptoms interfere with their daily functioning. Okay. Then for the mild, you talk about fewer symptoms than the major depression with significant disability, also of a shorter duration than for chronic depression. Depression can also be manifested in other conditions, like in bipolar. I mean, in bipolar disorder, you may have a mania cycling with, interchanging with depression. Okay. So you can find depression in bipolar, even though you could actually have mania running in bipolar, but then you can also have mania depression running in bipolar. So in that case, the depression there is no different. It is still depression as if it was standing alone. Okay. It's just that here when it resolves, probably the next episode the person experiences probably is a manic one. So they belong to both poles, the lower pole and the higher pole. Then you could also have depressive symptoms being manifested in dysthymia. Now, when you say dysthymia, you are talking about low grade or people who may not satisfy the criteria for depression, but then they are predominantly looking sad, you know, they are mostly looking slow in their actions. I mean, they are sort of pessimistic, but all these symptoms that they are having do not meet the criteria for major depression or for depression for that matter. So, and usually it runs for quite a long time. Someone can actually have dysthymia running right from maybe their adolescent ages. They've always been like that, you know, and then they can actually have depression, major depression occurring on top of this. Like when we in kidney disease, we say acute on chronic. So this becomes like an acute depression on a chronic dysthymia, which usually we will call double depression. We will call it double depression. I mean, but don't worry about that. Just let's focus on dysthymia. So people can chronically run a depressive course, but which is low grade and not enough to be diagnosed as major depression. The other reason why we need to be interested in depression is its association with suicide. You know, I mentioned that some of the symptoms are that they may have suicidal thoughts, they may attempt suicide, or they may even have thoughts of self-harm. Okay. So for those with major depressive disorder, evidence shows that close to 50% of them report feelings of wanting to die, desire to die. These feelings could be passive, you know. 33% of them actually consider suicide. So passive here means that they wish that they were dead. I mean, the way I'm suffering, I think I would be better off dead. That is a wish. However, 33% of them actually consider suicide. They themselves think that, let me take my own life. They consider taking their own lives. And then 8.8% of them actually attempt the suicide, you know. So this then brings us to a very important part. If we don't identify depression early, manage it properly, this can lead to suicide, you know. Now, more than 90% of those who commit suicide have a diagnosable psychiatric illness at the time of death, usually depression, alcohol abuse, or both. And the association between alcohol abuse and depression is quite clear, because when people are in their low mood, they may resort to using alcohol and other drugs as a way of boosting their mood, which may also lead them to addiction and other complications, you know. Then the question comes, who then is at risk of depression? Evidence shows that older adults are at risk. Young adults equally are also at risk. Women, pregnant, and then postpartum women are also at risk, you know. Now, women report depression about twice as often. So it's like 1:2. Men, my man is to woman. So more women report depression compared to men. This may then result from a greater, or this may result from a greater likelihood to discuss depression or to seek help. Reason, I mean, what we are seeking to say here is that chances are that the reason why we seem to be getting more women than men is because women probably are reporting. Because it's what is reported that is captured in data. That is then propounded, brought into literature. So if it is not reported, you cannot report it. I mean, you cannot put it in literature. So it probably might not necessarily mean that more women are having depression than men, but it's because more women may be reporting compared to men. Now, let's look at depression amongst women. We know that depression is the second leading cause of disease-related disability amongst women. Now, 1 in 4 women will suffer from major depressive episodes during the course of their life as compared to 1 in 10. Again, it could be the case that more women are reporting. Women may be more likely to discuss depression or to seek help. Like I said, might be the reason for the 1 in 4 against 1 in 10. Women of childbearing age are at an increased risk of major depression because of pregnancy and new motherhood issues, since these increase the risk of depressive episodes. Okay. Now, among the elderly, nearly 35 million, evidence from America shows that nearly 35 million Americans aged 65 and older, and an estimated 2 million have a depressive illness. So it could either be major depression, a dysthymic disorder, or bipolar disorder, like I explained earlier. Symptoms of clinical depression can be triggered by chronic illnesses. And don't forget, the older we are, the higher our likelihood to develop all these chronic illnesses. So Alzheimer's disease, Parkinson's disease, heart diseases, cancers, arthritis, and all. They easily predispose elderly people to developing depression. Depression is one of the most common conditions associated with suicide in older people, So if more elderly people are likely to be depressed, then suicide is also will be common among that age group. Individuals aged 65 and older have the highest rates of suicide, And high suicide rates among older people is largely accounted for by white men. A lot of white men are found within that bracket. Among the young people, 10%, evidence shows that 10% of university students have been diagnosed with depression, including 13% of women in the university, Lifetime prevalence for major depressive episodes are highest among young adults between the ages of 18 to 25. And suicide, again, as we know it, is the third leading cause of death amongst people who are aged between 15 and 24. And we have already said that 90% of people who commit suicide, or who commit suicide or die by suicide, had some depression. Other risk factors, like I mentioned, the genetic thing, so family or personal history of depression. So if the person has been diagnosed with depression in the past, they are likely to have another episode. Substance abuse problems. Most people who abuse substances at the end of the day also have depression in the background. A major life stressor or a change in life event, like I mentioned earlier, if you lost your job, you lost a loved one, chronic conditions too. So how do you diagnose this? So if you came to meet me or any of my colleagues or any mental health person in the clinic or in the consulting room, we would take a history from you. We will be interested in knowing what symptoms you are experiencing. How long have you been experiencing these symptoms? How are these symptoms affecting your activity levels, your occupation, your social life, And then we may run some standardized tests or screening tools. We may run some lab tests. We may do maybe EEG to look at your sleep pattern, And then once we're able to pinpoint a diagnosis and diagnose you as having depression, then we may then think of how then do we manage you. Our treatments are in several modalities. We have the biological or the the pharmacological model, and then also the non-pharmacological model. Non-pharmacological, we could have psychotherapy. You could have electroconvulsive therapy. Pharmacotherapy, I mean, there are several drugs that your clinician will juggle around and then choose the best one that fits your condition. If your situation is said that you are sleeping too much, maybe a drug like fluoxetine could be given. If maybe your condition was said that you are struggling to sleep, maybe, and your appetite is also bad, maybe a amitriptyline, maybe, and others could also be chosen for you, So depending on what situation you present or what symptoms of depression you present to your clinician. So on this is a brief one about depression. I move to anxiety. Now, when we talk about anxiety is a very common thing that we all experience. So ordinarily, one may say, why do you even waste your time? Because it's something we experience every now and then. So apart from we experiencing it every now and then, it can be a very difficult situation for certain people, which we need not take for granted. So anxiety disorder is said to be a chronic condition characterized by an excessive and persistent sense of apprehension, with physical symptoms such as sweating, palpitation, and feeling stressed. A sense of apprehension, a persistent sense of apprehension, excessive. So it's like some fear of the unknown, as if something evil is about to happen to you. It's not about being pessimistic, but it is that sense of apprehension. You don't know what is going to happen, and it keeps you worried. Something that ordinarily nobody would be worried about, but it keeps you, entangled in it, and then it's stressing you up. In general, anxiety disorders are said to be a group of heterogeneous illnesses that will develop before age 30 and are more common in women, unfortunately. Our sisters and wives, mothers also fall here again. Individuals with social issues and those with family history of anxiety and depression, Now, in the States, the 1-year prevalence rate for anxiety was found to be 13.3% in persons aging between 18 and 54. So predominantly the adult population is quite common. 10.6% in those over the ages of 55 years. So it's commoner amongst, if you like, the working class compared to the retirees. Now, in terms of its etiology, just like all other most mental health conditions, you may not necessarily be able to say this is the exact cause of anxiety, because once you say this is the cause, then you are saying that anytime that thing is present, you should expect those symptoms to appear. So if you say the female the plasmodium parasite is the cause of malaria, yes. Once we test you and we find it, we do a thin film and we find it in there, and we're able to count the number of parasites in your blood, we're expecting you to show signs and symptoms of malaria, So that is cause. But in this particular situation, it becomes difficult to talk about cause because you may find the same things might be found in two different people. One may have the symptom, one may not have the symptoms, So, but genetic predisposition is still a factor over here, like we saw in depression. Environmental factors, early childhood trauma, traumatic social experiences can all trigger an individual into developing anxiety. So like a child who was raped during their developmental years, or their developmental years, may end up being scared of men in general. So anytime they see a man, it triggers some anxiety in them, Known or unrecognizable medical conditions. Some medical conditions can also trigger some of these symptoms in an individual. Substance-induced, like over-the-counter medications, the herbal preparations, and then substances of abuse. Now, manifestations of anxiety usually will come in 3 aspects. It can manifest physically, behaviorally, and cognitively, So in terms of the physical manifestation, someone experiencing anxiety may have headaches, nausea, trembling, sweating, and then palpitations, Now, there's increased heart rates, etc., and many other physical symptoms. Okay. Now, the behavioral symptoms may include avoidance behavior. So because of these physical symptoms they experience, when they feel like they don't want to enter into an environment that will bring these symptoms they hate so much. So they try to avoid. So you may have people who may suffer social phobias like the agoraphobias, dependent behaviors So they are always trying to recoil and then seek, solace or seek refuge in other people. So they become dependent, and then also an aggressive or agitated behavior, Then the cognitive aspects or cognitive manifestation maybe it may include worry, fear of losing control, apprehension, again, fear of the unknown, So apprehension about the future, the fear of the unknown, confused thoughts, difficulty concentrating. They cannot think about the things that are they are always thinking about the things that are getting out of control. They feel like they are losing control. But really, what are you losing control? What are you losing? That same situation for which they are feeling this way, other people are in the same situation but are not exhibiting similar symptoms. Okay. Then types of anxiety disorders. You have the generalized anxiety disorder, you have the panic disorder, the phobic disorders, post-traumatic stress disorders, and then the obsessive compulsive disorder, the one we call OCD. So for the generalized anxiety disorder, it is the chronic anxiety state associated with uncontrollable worry. In fact, for generalized anxiety disorder, there is no trigger. They just get anxious about just doing everyday things. Their regular routine will trigger anxiety in them. Patients with generalized anxiety disorder have persistent, excessive, unrealistic worry associated with muscle tension, impaired concentration, and insomnia. Okay. Complaints of shortness of breath, palpitations, and tachycardia are relatively rare. So they usually will not experience these particular ones, usually. Now, alcohol abuse and dependence are common in generalized anxiety disorder. So when people feel this way, they are likely, like I mentioned earlier, to resort to the use of substances to deal with their anxiety. And in fact, nicotine use has also been found to be associated with people who feel anxious more often. People who feel anxious more often. So I guess like some of the things I mentioned, the risk factors, again, if there was a family history, increased stress, exposure to physical or emotional trauma, job losses, poverty, and then also drug abuse. Some of the symptoms, I guess I had mentioned them earlier when I was describing the condition. Panic disorders. So this is also a type of anxiety disorder. Panic disorders are defined by the presence of recurrent and unpredictable panics, which are distinct episodes of intense fear and discomfort with a variety of physical symptoms. Okay, so usually for a panic, so you have something like maybe for a panic attack, just for a short while, then maybe just once, then it ends there. So it comes to the palpitations, the usual maybe tremors, shaking, and all that. But for a panic disorder, when it becomes persistent, when it becomes recurrent, then we say that this one you are having a disorder and not just an attack. What are some of the symptoms that you might find or you should be looking out for in people with panic disorders? It could be psychological, it could be physical, and it could also be cognitive. Okay. So in psychological symptoms, you can have situations such as depersonalization. So a situation where it's as if they are not themselves, they are out of themselves, derealization, they are unaware of their surroundings, what is happening around them. Okay, fear of losing control, fear of going crazy, and the fear of dying. These are some of the things, psychological symptoms that people with panic disorders. And let us also mention that this usually occurs for a short while and it goes away, only to reappear or reoccur on a different date, usually when there is a trigger. Now, the physical symptoms could be abdominal distress, chest pain and discomfort, chills, dizziness, lightheadedness, feeling of choking, hot flashes, palpitations, nausea, paresthesia, shortness of breath, sweating, tachycardia, trembling, or shaking. Again, this usually will last for a short while, disappear, only to come back after there is a trigger. Phobic disorders. So like I mentioned earlier, because one of the things people with anxiety would want to use to defend themselves is to stay away from the sources of their anxiety. So one of them could be like the agoraphobia, where the fear of crowd. When they're in a crowd and they are supposed to present, they are supposed to talk, then it becomes a whole big problem for them. So for such that they will try to avoid being in the midst of people. The other specific phobias where people fear specific things like heights. People are afraid of even some insects, animals, and all that. We are all afraid of snakes, but some people's fear is to the extreme. Is to the extreme. So for specific phobias, it is a specific phobia is marked. It's a marked and persistent fear of circumscribed objects. So specific situations like insects, like heights, blood, public transportation and all. Now, apart from contact with the feared object or situation, the person is usually free from the symptoms. So if they have not come across a snake, if no one has mentioned snake in this room, everything is fine until it is mentioned. Then they blow up, So most persons simply will avoid the feared object and adjust to certain restrictions on their routine activities. Okay. Now, for the social phobias, it is characterized by clinically significant anxiety provoked by the exposure to certain types of social or performance situations, often leading to avoidance behaviors. And then common physical symptoms will include blushing, diarrhea, sweating, and tachycardia. Now, agoraphobia is basically avoidance of places or situations from which escape might be difficult or embarrassing. So you're in a crowd. You are in a crowd. And so you've been given a task. And then because you are suffering agoraphobia, you are feeling like if I was in this party, this thing I'm going to fail. I'll get it wrong. And then I'll be so embarrassed that I cannot even find my way out. Okay. So because of that, once they enter into such an environment, it will lead to a panic attack or panic-like symptoms. Phobic disorders are quite common. They affect about 10% of the population. The patients usually avoid the phobic stimulus, and this avoidance usually impairs your occupation or social functioning. Okay, so assuming you are a journalist and then you are suffering from such a condition, obviously you cannot perform your task. Even as clinicians, you will obviously not be able to perform your task because you're always afraid you'll get it wrong. And then you feel like it will be so embarrassing. If you're a student in class, you cannot even get up to ask a question. If a teacher asks you the question, it doesn't matter whether you know the answer or not. Because of this feeling, you find it very difficult to express yourself. Common phobias will include fear of closed spaces, claustrophobia, fear of blood, fear of flying. Patients with social phobia in particular have a high rate of comorbid alcohol use. Again, they use these substances as sort of coping strategies. Then we come to PTSD, post-traumatic stress disorders. Patients with stress disorders are at risk for the development of other disorders like anxiety that are related to anxiety, like mood and substance abuse. Okay, so what are the components of PTSD? Reliving the experiences or re-experiencing symptoms. So for something, they would have suffered a particular trauma in the past. Okay, they would have suffered a particular trauma in the past. And then, so for some of them, it's delayed. These symptoms will delay. Everything seems to have resolved until 6 months after. Then these symptoms will start. That is the late onset. Okay. Then there are some of them, usually there's a post-traumatic, there's that state where immediately it's happening, acute stress reaction, where immediately the thing occurs, usually within up to 3 days, all the symptoms resolve and the person is fine and it doesn't occur again. Now, if it is lasting more than 48 hours onwards, then we are probably in the realm of an acute stress disorder, at least according to one of the manuals that we use. Now, the other manual says within that duration, even once it is not up to a month, it can still remain and be called acute stress disorder, okay, until we get to the 6 months where we can call it a post-traumatic stress disorder, okay. So it will be characterized by recurrent, intrusive, distressing memories of the trauma, recurrent, disturbing dreams of the event, feeling that the traumatic event is reoccurring or is recurring, it brings you what they call dissociative flashbacks, like flashbacks. You are always recollecting all the whatever happened, as if you are picturing them all over again. It may also have physiological reactions to remind us of the trauma, assuming that there was you've been in you maybe the military, those or someone who has witnessed an accident, a very brutal, fatal one, where maybe some people even lost their lives. So you saw how people's skulls were smashed with their brain matter all over the place. So anytime you are by the roadside and maybe you hear a vehicle apply its brakes and it makes some loud sound, probably similar to what happened before the trauma you experienced, you would realize that you begin to physiologically react. And some of those reactions we are going to see as we go along. Then other avoidance symptoms, you avoid conversations about the traumatic situation. You avoid thoughts or feelings about the trauma. You avoid activities that will remind you of the event. Then sometimes you even find it difficult to recall important aspects of the trauma. You lose interest. They normally will have a restricted affect, so their emotional reactivity, which is usually seen on the face, seem to be restricted in a particular way. They have just a narrow range of emotional reaction. So something that's supposed to be funny, that everybody is bursting into laughter, they only give a small smile and then they close back, more like a restricted affect. Sense of a foreshortened future, like because of the experiences they have, they do not even expect to have a career and all that. Like their foresight or their future, they think is truncated. All of these as a result of the experiences they've had in the past. Then there's the hyperarousal component, which is characterized by decreased concentration, easily startled. So they are sitting down, you just open the door and they are startled as if you've done something bad or something evil is about to happen to them. There's hypervigilance, there is insomnia, irritability, that's they easily get angry. Symptoms usually begin early, within 3 months of the traumatic incident, but sometimes it may delay. Some may believe it will start 6 months afterwards, or some even after a year. Symptoms must last more than a month. As like I was saying, within a month, the DSM says that is an acute stress disorder. But within the first 48 hours, it's acute stress reaction. If it exceeds three days and gets to a month, acute stress disorder. Now, a month afterwards, if the symptoms are still present, then that is a post-traumatic stress disorder. Then the other common one that we always hear about, obsessive compulsive disorder. So in English, we usually say, oh, he's obsessed, he's obsessed. He's obsessed with something, he's obsessed with something. But when you talk about obsession, basically, you are referring to intrusive thoughts, ideas, images that find their way into a person's mind. Okay, so the person, they find their way into the person's mind. The person actually knows they are his thoughts, they are his minds. They don't believe that other people have inserted them. They find them to be silly, but they are not thoughts that they can do away with. Okay, they are not thoughts that they can do away with. Okay, so usually it will be characterized by obsessive and compulsive behaviors, and they impair everyday's actions. Imagine that you have the thought that your hands, the era of COVID-19, because every surface is contaminated. So that one is a thought that you have. So because you touch the surface, in your mind, your hands are contaminated. So you keep getting these intrusive thoughts ringing in your head. Then you ask yourself, but every other person has touched the surface. How come they are not really worried like the way I am worried? So you find the thoughts to be silly, but you can't do anything about them. It is not as if, this is different from thought insertion. It's not as if somebody from outside or an external force put them in your head or in your mind. But you know they are your own thoughts. They are unreasonable. They are silly, but you can't do anything about them. Then it leads to you now reacting to them. That's a compulsive aspect. Now acting in ritualistic manner, as if that is what will give you some relief from the thoughts you are experiencing. That is the compulsive aspect. Okay. So someone locks his or her door, and the person is having the impression that the door is not properly locked. So they are having doubts in their mind. That is the doubt. That becomes the obsession. Then because they have the doubt, they are now come and repeatedly check. They have to check a certain number of times to be sure that the door is properly locked. Okay. So those becomes the compulsions, the activity aspect of it. So you can have compulsive hand washing, compulsive checking, compulsive ordering, need to ask, need to confess, and all that. You could have mental acts such as counting repetitive words silently and praying, because they feel like these are the actions that give them some relief. But after doing these ones, they usually do not bring relief. The relief is just short-lived, and then the whole cascade will start again. It can be a very distressing situation. So for most people, I mean, if you have to do all these rituals in your house, wash your hands 10 times, check on your door about 10 times before you go to work, you'll always be late for work, and your employers will always have issues with you, you know. Management of anxiety disorders, yes. Again, like all other mental health conditions, we use what we call the biopsychosocial approach. So the biological will be the pharmacotherapy, the psychological is the psychotherapy, and then the social will be trying to at least correct some social event or social situations that probably are triggers with a particular person's condition. Okay, so for pharmacotherapy, obviously, if you went to the hospital, you will know how to deal with that. For psychotherapy, say specific therapies can be done like CBTs, individual psychotherapy for you, other things that will help you to be able to deal with this one. Exposure response could also be there. And then also desensitization, you know, are all things that can be done for people with anxiety and anxiety-related disorders. Now the big one. This one, we always hear about them mostly when you sit in the consulting room and you are getting referrals, most of the conditions they will refer to you, they will say, oh, psychosis, they will say acute psychosis, psychosis, NOS, not otherwise specified, something induced psychosis and all that. Now, a lot of the time, the whole idea is the person is seeking to say schizophrenia, but maybe not bold enough, so they will just drop psychosis. Psychosis basically means loss of touch with reality. That is all you have said. So you've not said anything. Loss of touch with reality. So we want to look at what schizophrenia is, so that the next time you hear about it, you want to write psychosis, or you hear psychosis, you want to be sure. Could it be schizophrenia? You know. Now, schizophrenia is a serious mental illness that has an effect on how a person feels, behaves, and thinks. So their feeling, their behavior, and their thoughts are affected by schizophrenia. Now, it's a mind or brain disorder, as some put it. Sometimes that's the condition people confuse with what they call multiple personality disorder. That is a different realm altogether. Now, how common is schizophrenia? It is said to form 1%. If the prevalence is about 1% of the general population. Okay. Now, if you had a sibling who has one of your siblings who has schizophrenia, then you have an 8% risk. Don't forget the general population has a 1% risk. But if you have a sibling with schizophrenia, you have an 8% risk of developing schizophrenia. If you have a parent with schizophrenia, your risk is about 12%. Now, if 2 of your parents have been diagnosed with schizophrenia, then you have a 40% chance or risk of developing schizophrenia. Then if you are identical twins, the one we call monozygotic twins, and then one of your twin or your identical twin suffers schizophrenia, then the person has a 47% chance, almost 50% chance of developing schizophrenia. Again, you would look at them and see that for monozygotic twins, they share virtually everything in common. But how come the risk is not 100%? It then tells you that other factors come into play. So it is not a straightforward inheritance. It's not about the inheritance, you know. What are some of the causes? Again, no one knows the exact causes of schizophrenia, but multiple possible factors have been identified. So genetic factors, yes. So you have a family history of schizophrenia, and so it puts you at an increased risk. Brain chemical imbalance. I mean, we all know about the dopamine hypothesis, serotonin hypothesis. We know about several of those ones. Then environmental factors like malnutrition, which we will see, family history, again, genetic predisposition. So if you look at this diagram, you will see that having genetic predisposition plus environmental, social, and psychological factors all come together to now cause the neurodevelopmental abnormalities in the mind or in the brain. Then the brain's dysfunction follows. Then the imbalances of the neurotransmitters, then the schizophrenia comes as a result. So no single one on its own can be traced directly to schizophrenia. So it is when all these factors come together in synchrony, then they now produce schizophrenia. As far in terms of the genetics, defects, I mean, some of these things are quite technical. I mean, not necessarily need to go into them, like I had mentioned earlier. Yeah, so environmental factors such as stress-inducing environmental situations like social pressure, physical or sexual abuse, loss of a loved one, hormonal changes, malnutrition, and early exposure to viruses could be environmental predisposing factors. Okay. The major brain changes that occur during puberty have also been identified as possible contributing factors. Again, none of these factors mentioned alone can be said to be the cause of schizophrenia. It is a constellation of them. When they are all put together, they all contribute minute quantities, and then they're able to form this bad, if you like, condition. Family history. If one's mother, like we had mentioned earlier, like statistics I gave earlier, this is just reiterating that. So now if someone has schizophrenia, how will we identify them? Some of the symptoms of schizophrenia have been put into three major categories: positive symptoms, negative symptoms, and cognitive symptoms. Okay. So the positive symptoms, the symptoms usually reflect an increase in the presence of abnormal behaviors. These active and abnormal symptoms may include, so don't forget, positive symptoms are like an increase in the symptoms. So we say they are positive, that's plus. So there's an increase. So hallucinations, what everybody is seeing, you are seeing beyond what everybody is seeing. So you're adding more. So what everybody is hearing, you are hearing beyond what everybody hears. Again, you have added more. So thought disorders like delusions where they believe other people are doing what and what that no other person believes. You have added something more to what ordinarily we expect everybody to believe. Then other, if you like, movement issues. Okay. Then negative symptoms, these are diminished. So what everybody has, you seem to have them reduced. Okay, so that's the simplest way of understanding positive and negative symptoms. What everybody has, yours seem to be diminished or reduced. So that's the negative. Now, so loss of interest in everyday activities, anhedonia again, appearing to lack emotion. So your emotional reactivity in terms of your affect is compromised. It's either restricted, is blunted, or is flattened. Reduced ability to plan or to carry out activities. Okay, neglect of personal hygiene, social withdrawal, and then loss of motivation. That's immotivation, you know. So you see, all these ones are like decrease, 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 and that's the negative symptoms. Then the cognitive symptoms, they involve problems with thought processes. Okay, so these symptoms may be the most disabling in schizophrenia because they interfere with the ability to perform routine daily activities. Problems with making sense. So the person is speaking, and excuse me, but they are speaking gibberish. What they are saying don't make sense. Difficulty in paying attention, and then also having memory problems. Okay, these are some of the symptoms that people with schizophrenia would manifest. This diagram, I'm not too sure if it's very clear enough, but we see a gentleman in there, and some of the symptoms they are, some of their thoughts. Now, down there, he says, maybe I am Jesus. Then he says, they are following me. Aliens are contacting me. The radio told me to freeze all that, the radio told me to free all the animals in the zoo. All the animals in the zoo. Okay. So I saw elephants. So you realize that this person, some of the things the person is even thinking or talking about do not make sense. How can you say aliens are contacting you? This is bizarre. So with people with schizophrenia, they will be having these bizarre delusions. Okay, they have these bizarre delusions. By saying that the radio told him something about freeing animals at the zoo, it should tell you that there's a discussion possibly on the radio, if it was true that there was any radio thing, which is about animals in the zoo. And he thinks it's in relation to him, like a referential delusion. So that could be. It could also be the case that really in his hallucinations, he had this auditory hallucination where he heard people telling him to go and free animals at the zoo, possibly a second person auditory hallucination, or he heard them discussing it. So maybe it's a third person auditory hallucination, you know. Now believing maybe I am Jesus. Well, maybe if we inquire further and he holds on to the fact that yes, he is the Jesus Christ, chances are that it's a grandiose delusion, you know. Then he's asking himself, where are all these voices coming from? So he's hearing the voices and he's wondering where the voices are coming from. Okay. Now, when people have schizophrenia, I mean, the old teaching, we used to talk about being schizophrenia could be catatonic, could be paranoid, disorganized, residual, or undifferentiated schizophrenia. So just that the new classification do not necessarily have all these, but these are, if you like, the very common teaching that most of us have received already. So catatonic schizophrenia, paranoid disorganized schizophrenia, residual and undifferentiated. So all these ones have characteristic features, okay, that are used to diagnose them. So if you take like paranoid schizophrenia, it is they predominantly show positive symptoms like the auditory hallucinations, like the delusions, you know, they are showing those ones. I am this, I am that, I am hearing voices talking to me and all that. So predominantly, that is what characterizes them. Disorganized schizophrenia, so they're normally negative symptoms with disorganized behaviors and speech. So when you have these three predominating in an individual's with schizophrenia, then we say this is likely to be a disorganized type. Then residual type, basically you are talking about, I mean, all the person probably had all the positive symptoms and with a few negative symptoms, but now almost all the major or the positive symptoms have all resolved, and he still has a few of the negative symptoms here and there. We say he has residual schizophrenia. Undifferentiated schizophrenia is that, yes, the person meets the basic criteria for diagnosing schizophrenia, but then he doesn't fall within any of the major categories. So we say he has undifferentiated schizophrenia. Now, catatonic schizophrenia comes with a lot of, if you like, physical manifestation. So the person probably could be rigid. The person probably is not eating. The person is probably, yes, the person is not eating. Probably the person is not even, doesn't even want to drink water. They are maintaining unusual body postures. There are some staring gaze and all that. Other symptoms like we call other symptoms like Gegenhalting and all. I mean, those are quite technical, so don't worry about them. But they are showing things about rigidity, negativism. They are probably not eating. They are not drinking. Their activity levels are down. You know, then we are able to say no. This person probably has a catatonic schizophrenia. For almost all these conditions, the management will be the same. I mean, it's still about antipsychotic. Just that with catatonia, some benzodiazepines would really help. And I had an experience recently where I was contacted by some nurses, some of my nurses in a particular district. They had a case of catatonic schizophrenia. They were so confused about it. So they called me and discussed. I was like, but this is catatonia, catatonic schizophrenia. So either you send the patient down to me, or what do you want to do? They said that the relatives were unable to bring him. I mean, paying for transportation and all was a challenge. So I encouraged them that, well, if that was the case, they should start some benzodiazepines. The next day they called me that, oh, when they started the benzos, the patient is up and he's fine. So they are continuing the orals. And well, I guess he's still fine now because they never go back to me, you know. Now, how do you diagnose schizophrenia? So 2 or more of the following must be present, according to the DSM. You need hallucinations, you need delusions, you need disorganized behavior or catatonic behavior, you need disorganized speech, and they also need some negative symptoms. And I think we described all these things at the top. Hallucinations, either second or third person auditory hallucinations, delusions, whether they are paranoid delusions, grandiose delusions, um, um, delusions of reference and all. Disorganized behaviors or catatonic behaviors, disorganized speeches, where maybe speech salad, neologism, and all may fall. Negative symptoms, like one we mentioned, the anhedonia, we talked about the immotivation and all that, So these symptoms, as far as the DSM, the American Diagnostic and Statistical Manual is concerned, they have to run for at least 6 months before you can make the diagnosis. However, the ICD, International Classification of Diseases, actually says these symptoms should run for at least 4 weeks. So with the ICD, you diagnose earlier than the DSM, Now, when someone has schizophrenia, what do we do? Depending on the maybe permit me to say the severity of the condition. If the person was aggressive, destructive, the person had become a harmful for the family, he's refusing to take medications and all that, the person might require institutional care. Okay. Then again, like I said, for all types of schizophrenia, antipsychotics. Then when they are stabilizing, they may also require some psychotherapy. Okay. And then also there could be the community approach, like elsewhere, they practice the at the community level. So if someone has schizophrenia, your best shot is to get the person to come to the hospital where he or she can be properly diagnosed and then the appropriate management started. Way back, I saw this, I think in the Yellow Bible, the Oxford Handbook of Clinical Medicine. They had a saying somewhere like, if you talk to God, you are praying. If God talks to you, you probably have schizophrenia. I mean, this is not true, 100% true. Okay. But we should bear in mind, this is just to say that when you are communicating with God, we agree that you are praying. But if you say you are hearing God talk to you, chances are that you are hallucinating. Aha. So let us bear this in mind. Thank you very much for listening. Albert, you can take over. Thank you.
Thank you. Thank you very much, Dr. Dennis. Thank you very much. That was very, very detailed and elaborate. And I'm sure most questions have already been answered. We appreciate you so much. Thank you very much. And we could all tell that he's very, very practical, hands-on. And of course, like I said, he's a man of data. All right. Thank you very much, Dr. Dennis. And to those of you who join us a little late, no worries. I'll be sharing the recording of this, the entire presentation on the YouTube channel. So please kindly subscribe to the YouTube channel, put the notifications button on. And when I share the recording, do us one favor, just share it to as many people as possible. The details that he went into depression, anxiety, and schizophrenia, this is what you need to know. So if you have a friend who has a condition or somebody who wants to know more, or you want to have an idea what this is all about, just go to the YouTube channel and watch the whole presentation. And if you have any questions, you can drop it in the comment section on YouTube and it will be addressed. Thank you very much. It's time for questions and answers. Please, if you have any questions, drop it in the comment section and drop it in the chat box, and Dr. Dennis will gladly answer you. So time for questions and answers. Please drop your questions in the comment section and in the chat box, and Dr. Dennis will gladly answer you. Now, time for questions and answers. So we are waiting for your questions and answers. My first question, Doc. So I'm speaking on behalf of other people. Let me ask a question. The conditions that you took us through, Doc, is any among them that is curable?
Okay. So, but this is the question that anytime I'm asked, I really want to take a lot of a deep breath before I answer. Aha. Um, so the reality is that most of these conditions are actually considered to be chronic. Okay, they run a lot of time, they run a chronic course. Okay, so depression is one that you may have an acute depressive condition. I mean, once it happens once, the first time. If we are lucky, after initiating the right treatment and then you being compliant on treatment, chances are that you have a good chance that you may not get it again. However, you can way after you have been treated and everything seems to have been fine with you, it can actually occur again, because it can run a recurrent course. Okay, so in that particular situation, it becomes a chronic condition. And for something like schizophrenia, typically once you are diagnosed properly and it is proper schizophrenia, cure is a bit of a challenge. Normally, I advise all my patients that, look, let's consider this condition like the way we see hypertension, like the way we see diabetes. And then let's make sure we are taking our medication. Anxiety disorders, yes, if you are diagnosed with generalized anxiety disorders, the teaching is that you should be on treatment for at least a year and a half. And if your symptoms do not come again, we should taper it off gradually. A lot of the times, as you are doing the tapering off, they relapse. When they relapse, you put them back on the medication. After a while, you have to continue on it, possibly for a very long time. In fact, most of the time, I tell my patients that, look, you are going to have to be on this drug for a long time, so as not to make people feel as if you are condemning them to medications. But the reality is that a lot of psychiatric conditions are such that you may have to be on treatment, possibly for your whole life, Yes, Doc. So that's how I answer it, please.
All right, thank you very much. Now, some people also, I'm just asking on behalf of people, the aim of this webinar is to educate the public so that they get accurate info from the source. A lot of people ask the question of, are there no natural remedies that can take care of this instead of the orthodox prescriptions? People ask this question. What would you say?
Sorry, usually for most of these our conditions, we will say that our best shot is to do our best to see if we can prevent ourselves from developing these conditions than getting them and wanting to find remedies and natural remedies and all that. Yes, because you see, when I was talking about the causes, for almost all of them, I mentioned that the exact causes are unknown. So what would the natural remedies be treating? What would the natural remedies necessarily directly be treating? Okay. So your best shot is to protect yourself from getting this condition. Now, for those who have it already, what has been tested and proven, if you like, scientifically, are the ones that I would encourage you or advise you to want to stick to. A lot of the times, also in my mention, I mentioned that certain medications also trigger or tip people into developing some of these conditions, like the anxieties. Okay. And so sometimes what you call a natural remedy, well, may at the end of the day be the one that will tip you into another condition altogether. So the standardized treatment or what the evidence supports probably is what we should all go by. I mean, that would be my answer to it, please.
Okay. Now, the question I wanted to ask is exactly the question somebody has already asked in the chat box. So the person is saying, could it be spiritual?
Okay. Usually when I'm asked this question, especially in church, when I do a presentation, they ask me, could it be spiritual? Then I tell them that, well, to the extent that I stand in church with you and we all believe in God and all pray, yes, there could be some spiritual something. However, if I sit in my consulting room and people bring this condition to me, I consider them purely a biological problem or a medical problem. Okay. And so to the extent that we have medical basis for these conditions, then I'm more inclined to believing that it is a medical condition which I need to address medically. Now, when I was in Komfanoche, I had a funny experience. A woman comes to me and then she starts making confessions about she being responsible for the death of her grandchildren and all. and the daughter who brought her gets so angry and wants to react. So I encourage the daughter to wait. Your mother says she's a witch, isn't it? Let me give her my drugs. After giving her my medications, 2 weeks down the line, when she comes back, or let her come and tell me again she's a witch. If she says that, well, maybe we can believe her. Interestingly, after putting her on some antipsychotics and some antidepressants, 2 weeks down the line, she comes and we say, Mama, last 2 weeks, you said you were responsible for the death of your grandchildren. And she's now saying, why? How can she be the one killing her grandchildren? It's not true. She doesn't even know anything about the death of these children. So a lot of the times, it is when we spiritualize them and claim that they are as a result of some demonic attacks and all, we neglect what what we are supposed to do in terms of treatment. And then we end up coming out with worse outcomes. Okay. So even, yes, if you believe that it's a spiritual condition, you do your prayers and still adhere to our treatment. Chances are that your prayers with our treatment will be able to get good results. So that's how I probably answer it. Thank you.
Yes, very, very true. Thank you very much, Dr. Dennis. Yes, so no one is preventing you from praying or seeking spiritual help, no, but all we are advising strongly is once you are prescribed medications, please stick to it and continue your prayers and everything else. Don't just conclude that it's a spiritual something and you put your medications aside, because when you have a relapse, you are not likely to go to your pastor. You're likely to be sent to the hospital.
To the hospital,
and the doctors
yes.
are the ones who are going to have to help you out. All right. So I intentionally ask these questions because they are very common. A lot of people want to know. A lot of people get deceived by people who want to manipulate them and extort lots of money from them. They will scare you into telling you, oh, it is your mother who is doing you, it is your house people or something, and there's a ritual I'm supposed to perform for you. They will give you a lot of reasons. And other people might also deceive you that the medications from the doctors are going to do you more harm than good. You heard from Dr. Dennis. It's not true. All right. We work with evidence-based. Those things that have been tried and tested and safe for human consumption is what you'll be prescribed by any qualified doctor. So don't just go anywhere to seek whatever you want. So thank you very much. Any questions, please drop it in the chat box. Like I said, the presentation was very elaborate and very in-depth. So a lot of people have their questions already answered. But if you still have any question, please feel free, drop it in the chat box in the comment section, and Dr. Dennis will gladly answer us. And in addition, if you joined us not long ago, I've dropped the YouTube link in the chat box. Feel free, subscribe and put the notifications button on, and I will drop the recording in a few minutes after we end here. And you just do us one favor, share the link to as many people as possible. A lot of people have no idea what any of these conditions are about. And there are a lot of people who are suffering from this condition. It is real, it's not made up. Lots and lots of people are going through a lot of silent battles. Most people, all they need is the enlightenment to get to understand, oh, what I'm going through could be depression, could be anxiety, or could be this, or could be that. That is all some people need. And the advice is seek help from appropriate quarters. Thank you very much, every single one of you. Is there any other question apart from the one that has been asked by Benis Ado? All right, any other question? Any other question? Any other question? Adiza, yes, you say you are coming for consultation. No problem, anytime. Adiza Sulemana, well done, anytime at all. You can reach out to any of us and we'll be glad to help you. We have a few seconds more to go. Do you have any question to ask Dr. Dennis? The presentation was very clear. It was clean. It was detailed. Depression, anxiety, and schizophrenia. Everything you need to know was presented. So if you missed any part of it, all you need is to get the recording and go over it again, and you get clarified on everything that you need. Any more questions? Few seconds before I let our guest speaker go. Thank you very much, everyone. All right, so in the absence of any questions, Dr. Dennis, do you have any final words for us?
Yes. So, Doc, again, I would just want to thank you for this wonderful opportunity. Like I mentioned earlier, it's an opportunity to demystify mental health and then bring good knowledge to the doorstep of our people. I just want to use this opportunity to encourage each and everyone that let's go spreading the good news and telling people that there is help. There is help for people who suffer mental illnesses and mental health conditions. And then instead of abandoning them to prayer camps and faith healers and all that, the shrines where they are chained and maltreated, there is good help available. And so they should seek help from qualified personnel, and then they will get some, if like, relief from their symptoms. Yeah. Thank you very much, Doc.
All right, but there's a question that just dropped in. Somebody's asking, if a person with schizophrenia keeps or find reason to stay away from certain situations or places without any logical reason, how do you handle it?
So if a person with schizophrenia keeps or finds reason to stay away from certain situations, places without any logical reason, how do? Well, so again, with such a situation, you see, there is more you need to get from the patient, you see. So there are situations, in fact, there is what we call someone who has schizophrenia and then there could be a comorbidity. They could have other comorbidities, okay? The fact that they have schizo probably doesn't mean they cannot suffer any other condition or any other situation. So we need to have good information or good history from this person, interrogate it well, find out why they are avoiding those situations. Could it even be that they are hearing voices telling them they are evil? There's something evil there, for which reason they don't want to go there. Could it be their belief? Could it just be part of their belief system, that is making them do some of these things? So in that case, once you diagnose schizophrenia, it is treatment. Once we put them on treatment and the conditions seem to resolve, the chances are that whatever, if we're able to crack it, assuming it was a delusion, if we're able to crack the delusion, whatever was preventing him or her from going to some of those places is no more. And so the person is able to go to those places. But again, my caution will be, let us get further and better particulars from this person so that we understand what really is happening. Otherwise, I'm unable to say exactly what you should do. Thank you, Doc.
All right, thank you very much. All right, so somebody asked, what about bipolar disorder? What can be done? It's the same thing. It's the same thing. You have a condition, you see the specialists, and then you get the help. You stay on medications, you go for your regular reviews. It's the same thing. All right.
Yeah.
What is most important is the accurate diagnosis. The accurate diagnosis of the condition, and the rest is about the management. Somebody was asking, okay, when is the lecture again? So, like, Brights, I've dropped the YouTube link in the comment section. You can subscribe and put a notifications button on. When you go to the channel, there are a lot of other presentations on the channel, on the YouTube channel. Last 3 weeks, we did something on maternal mental health. The following week, we did something on adolescent mental health. Just last week, we did something on the workplace mental health. And today, we are doing something on depression, anxiety, and schizophrenia. Next week, we are likely to do something on addiction. And the following one, we're likely to do something on stress. So it's a series of lectures. So all you have to do is subscribe to the channel, put the notifications button on, watch, and share with your friends as well. We have lots and lots of experts who grace this channel. And one of them, of course, is whom you are hearing from, Dr. Dennis Daliri, who is a specialist psychiatrist located at Bolgatanga at the Presbyterian Psychiatric Hospital. He is a man on fire. All right. Thank you very much, Dr. Dennis. And thank you, every one of you. Okay, let me see. Thank you, every one of you. Thank you very much for taking time from your busy schedule to partake in this meeting. Thank you very much. And thank you, a special thank you. Help me, every one of you. A special thank you to Dr. Dennis for such an elaborate presentation. Thank you. And once again, I must say, it's been a plum, pleasing pleasure serving you all. Until I hear from you again, every one of us,